the chairs, ladies and gentlemen, I just want to thank to the organizers, especially to Murat Emret and Amos Korchin for their kind invitation. In my talk, I would like to focus on preclinical and clinical data together, because this is a very hot topic. You see, under normal physiological conditions, here is the glutamate release, and it influences the postsynaptic receptors, NMDA and AMPA receptors mainly. But what's the matter under the dyskinesia condition? There are several changes. One thing is that it is proved by Thomas Chase and Peter Jenner and others, there is a lot of glutamate release, so there is some kind of spillover of the synaptic glutamate, and it binds to especially to the M-glu receptors, the metabolic glutamate receptors, and it is some kind of a little bit volume transmission, so it is not the classical synaptic transmission. In the same time, there is a phosphorylation of the postsynaptic receptors, making these receptors very sensitive to the transmitter. So a lot of alterations are going on. Again, spillover of glutamate influencing the M-glu receptors and the supersensitivity of the postsynaptic receptors, consequence of phosphorylation. What kind of possible beneficial aspects we can discuss? Neuroprotection, let's say anti-parkinsonian effects, and anti-dyskinetic effects. Concerning neuroprotection, I don't want to go in deeply because it's a huge story, but all we know that complex 1 deficiency, the NADH ubiquinone oxidorreductase deficiency, first was written by Peter Riederer and Heinz Reitman in the late 80s, maybe contribute to the development of the deficiency of the nigra neurons. And at the same time, a lot of excitotoxicity release is going on in Parkinson's conditions. And finally, these impaired energy cells are destroyed by the excessive glutamate activity. What about the preclinical models? You see, MPTP, it is just influences the complex 1. A lot of studies have been performed. I don't want to go through all of these studies, just to mention that the protection by amantadine is NMDA receptor independent because it inhibits MPTP uptake, decreases microglia inflammation, and enhances the gDNF production in vitro. So despite the fact that we consider amantadine as an anti-glutamate agent, it has many other effects, and maybe it's also contribute. Otherwise, amantadine introduction was suggested, as far as I know, you better know Dr. Horowski as myself, by Peter Riederer, maybe you have. And concerning the, you can see that several of the compounds has a protective effect. I just want to mention kynrenic acid because at the end of my presentation I would like to focus this. Memantine also has a protective effect. And as you can see that in the case of MK801, that is very controversial data. What about the 6-hydroxydopamine model? All we know that it was originally introduced by Urban Ungerstedt. His PhD was basically in the late 60s related to this model. And as you can see that MK801 has I don't want to go all of these things, but kynrenic acid also has a protective effect. What's the matter with methamphetamine? Several agents is able to show neuroprotection. And quinolinic acid, which is the end product of the kynrenic pathway, it is a weak excitotoxin agonist. The endogenous kynrenic acid inhibits the quinolinic acid-induced alterations. And you see, I just want to mention that the so-called classic NMDA receptors are a little bit controversial because in the same time, these compounds has a BDNF decreasing effect, so not as clear the neuroprotection as I will show, for example, MK801, as I will show later with other types of blockers. And indeed, in preclinical studies, as you can see, very controversial data with MK801. It was never introduced in the clinic because it's a lot of side effects. And what are the novel insights into the NMDA receptor excitotoxicity? I think that these so-called NRTB selective NMDA antagonists may be interesting and as I told to you, the metabotropic receptors, and it seems that they have more clear effect, but I want to mention that they are some point of view extrasynaptic receptors, so not the classical transmission is going on in this case, but the so-called volume transmission, which is maybe more important than the classical synaptic transmission. What's the matter in patients? You see, it is an old study. Amantadine treatment is an independent predictor of improved survival in Parkinson's disease. But to tell you the truth, concerning neuroprotection, as far as I know, no one study, clinical study, which would clearly show neuroprotection. In my mind, this neuroprotection is one of the biggest problems in neurology, because we face the same things in nearly all of the disorders. And what about the so-called anti-Parkinson effect? The basic concept, I don't want to repeat it. And the possible action of NMDA antagonists has an anti-glutamatergic effects on NMDA receptors, increasing dopamine release and reducing acetylcholine release from interneurons. But I better to say that not NMDA receptors. It's better to think about excitotoxin inhibitors. What about the data? You see the neuroleptic model, it was shown that several of the compounds, including 7-chlorokinolinic acid, was effective. Dextromethorphan was effective, and in this case, MK801 was effective. What about the monoamine depletion? This is an important drug because, as far as I know, Arvid Carlson in the beginning of the 60s injected with reserpine rabbits, and after he had L-Dopa, and the rabbits opened their eyes, thanks to, although the reserpine is a general monoamine depleter. And you see this reserpine effect was also inhibited by several compounds, including this kynrenic acid-like compound. MK801 in most of the studies was effective. And also the 6-hydroxydopamine model, as I told to you, that is Ungerstedt, who was discovered at the Karolinska, and the 7-chlorokinolinic acid was effective, Amantadine was effective, and MK801 was in some studies effective, in others not. And the MPTP model, as I told to you, that it binds to the NADH, it inhibits the complex 1, the NADH ubiquinol oxidoreductase, and consequently it makes an intracellular energy impairment. And some of the drugs was effective, including kynrenic acid, and also memantine, and the MK801 was ineffective. So selective NR-TYB antagonists maybe have a better pharmacological profile. What's the matter in clinics? And here comes the problems. Because with Amantadine, in 1969, a series of promising that open-label studies have been performed. But in 2003, the Cochrane database, which made a systematic review, told there is not really insufficient evidence to suggest this. So if I want to be really correct, there is maybe insufficient evidence. Concerning memantine, you can see that it was effective in several trials, but any NR2B antagonist, unfortunately, was ineffective. But we should see about the metabotropic receptors. What's the matter with anti-dyskinetic effects? Instead of the nigrostriatal injury, the discontinuous pulsative stimulation of the dopamine receptors leads to altered synaptic plasticity, as I told to you, and hypersensitivity, I mean the phosphorylation of the synaptic receptors, the NMDA receptors, and overactivation of the striatopallidal circuits. These classical studies usually use MPTP and the repeated application of levodopa, and consequently in monkeys, and very fast dyskinesia developed. So that was the basic in most of the models, or of course 6-hydroxydopamine. What we have, or these people have found that Amantadine has a nice effect, and also I just want to, dextromethorphan has a nice effect. Otherwise these were rat studies. MK801 also seems to have some good effect. And if we see in clinical trials, the evidences, because as clinicians, we all the time looking after evidences. The Cochrane database suggested insufficient evidence in this 2003 trial. The AAN made a level C evidence concerning using Amantadine, and the meta-analysis showed a beneficial effect. Concerning memantine, it was proved 3, maybe more trials, and the same with dextromethorphan. And finally, I would just mention to an interesting field which is maybe less known. Kynureninic acid is an exciting compound because it binds to several receptors, including the NMDA receptor, strychnine-sensitive glycine receptor, to the ampakainate receptors, to the alpha-7 nicotinic receptor, and binding to all of these places has some protective effect. And the reason why I say is that because we have excitotoxin, glutamate, aspartame, glycine, glycine, but neuroprotective agent, not so many neuroprotective agents do we have in the brain. Otherwise, here is quinolinic acid, which I mentioned, one of Stein studied, and this is an agonist. And this compound is synthesized mainly in astrocyte, while quinolinic acid in glial cells. And in Parkinson's disease, there have been some studies which showed that the compounds made a free radical generation. This compound otherwise increased in the post-mortem brain areas, and 3-hydroxyquinoline has a free radical generation effect. As I told to you, that quinolinic acid is an NMDA receptor activator, and then quinolinic acid is a blocker. And it seems that this alteration showed that in Parkinson's disease, maybe there is some importance of this mechanism. What are the concluding remarks? Are NMD antagonists are useful in Parkinson's disease? I should say yes, because that is my responsibility, but I also feel the weak points of this. May protect neurons from progressive degeneration. It has not been proved according to clinical evidences, but a lot of preclinical studies suggest that may potentially substitute dopaminergic therapy. Otherwise, if you push down the NMDA receptor activity, there's an inverse correlation with the dopamine flow and can control therapy-related motor complications in L-DOPA-induced dyskinesia. Recently we summarized this. It was just came out a month ago in Nature, this new data, and we are looking forward to further studies in the field of kynurenins. Thank you for your attention.